is Jens Schmidt. I'm a neurologist.
Yeah. Oh, there. Dr. Schmidt, please.
Okay. Can you hear me all right now? Okay. So, good morning, everybody. My name is Jens Schmidt, a neurologist from Göttingen in Germany. It's really a pleasure to be here. I'm really excited, and I thank the organizers for giving me the opportunity to show a few data on the research in IBM and recent developments. If anything is unclear, please don't be shy, interrupt me at any time. There should be plenty of time at the end of the talk for questions, but still, if you have anything urgent in between, just stop me and I'll try to answer all of the questions. Is this loud enough? Otherwise, I don't know if I can move the microphone a little bit closer. So is this okay? All right. So let's get started. All of you know this. This is a patient with Inclusion Body Myositis, and this is nestled around other neurologic diseases. And I propose that there is one common theme that connects all of these conditions. Would anybody have a guess what that is? Protein fold. Yes, very good. Protein fold and protein unfolding. That is true for most of these conditions, but not multiple sclerosis and not the stroke. Any other guess? What deposits? Plaque deposits, yes. Plaque deposits are present in, well, sort of plaques in IBM. They are certainly present in Alzheimer's and similar in Parkinson's. So the commonality of all of these diseases is that we have a complex mixture of inflammatory and degenerative mechanisms. So, on the one side in MS, this is an inflammatory disease, but still we have degenerative mechanisms. Alzheimer's, Parkinson's, these are neurodegenerative diseases. And the protein unfolding, folding machinery is disrupted, and we have problems, and we have amyloid in the brain, but at the same time, inflammation is important. On the one side, to clear some of those plaques. On the other side, to make an additional cell stress on the neurons and to attack them, and the same holds true for the stroke. And of course, in inclusion body myositis, all of you are aware, we have proteins that lump together and form the vacuoles and the inclusions, that what gives the name of the disease. And all of these proteins, they lump together inside the muscle fibers, as you can see down here, and I'm sure most of you are already aware of. And then in the same muscle, this is a cross-section of a patient with inclusion body myositis. In the same muscle, we have inflammatory cells that attack the skeletal muscle fibers. And I would like to discuss with you in the next maybe 30-45 minutes what we know of this complex mixture of inflammation on the one side with the inflammatory cells and the degeneration with the protein accumulations on the other side. There has been a review of many very knowledgeable people on this. Olivier Benveniste, for example, many of you know that name, from Paris. He's also on the Myositis Advisory Board, Werner Stenzel, and then many others from Europe. And they made the title Amyloid Deposits and Inflammatory Infiltrates in Sporadic Inclusion Body Myositis. The inflammatory egg comes before the degenerative chicken. So this is, of course, quite or maybe not quite, but it is still provocative, because we do not have a true answer to this, but I think, and I hope that I can convince you within the next 30 minutes or so, that there is a reason for this title, that at least I think we have more evidence to support the fact that the inflammation comes first, and then the degenerative chicken. But there is, I think, ACTA, this link, I will put these slides as a PDF version for a download on the website. And this is copyright protected, of course. These are international publications, and depending on the journal where such studies, some of them, like some ACTA, the ACTA neuropathology, depending on the year, sometimes they become available open access. So the ACTA neuropathological communications, they're always open access. Okay, so we have the inflammatory chicken, the degenerative egg, and we have a complex network of mechanisms connecting these two. So we will start with the chicken, with the inflammation. And before we go into details, I would like you to know of my coding of the slides to make it a little bit easier to digest, hopefully. In most of the slides, you will see a small cartoon telling you where does the study, where does the information come from, either from a blood sample study, or from muscle biopsy samples, or from a clinical study, or from cell cultures, or it's a mouse study. So now, regarding the specificity of the inflammation, I just picked out one paper, but there have been numerous papers, publications internationally that have shown basically the same thing. This is a fingerprint analysis of T cells. So T cells, all of us need in order to get rid of cells that are infected by viruses. And then the T cells come and attack that cell and get rid of it to clear the infection. Now, this is a very difficult method that can pinpoint an individual T cell. And with this method, it is called spectrotyping. And with this spectrotyping analysis, several investigators throughout the world have clearly shown that in the skeletal muscle and in the blood of patients with inclusion body myositis, we have a specific response of T cells, and that they clonally expand, that they grow, and that they're activated in the skeletal muscle, which means that these T cells, these inflammatory cells, they don't just happen to be in the muscle just by chance. They have been recruited into the muscle because there is a specific signal that calls them into the muscle, and they are in the muscle, they are activated to grow in the muscle, and you can follow up these T cells over years, and they can go away by treatment. So this cartoon here shows that there are certain molecules on the surface of these cells. It's called ICOS, you don't have to remember, but for those of you who are interested, for example, this is inducible co-stimulatory signal, and this is an activation signal. And it's so unique because it makes contact to the muscle fiber. And the muscle fiber itself has the ligand, ICOS ligand, which is upregulated on the muscle fibers and which can tell the T cell, you should grow, you should multiply yourself 10 times, 100 times, 200, 500 times, and then the inflammation gets going, and then those T cells that get activated in the muscle then attack the surrounding muscle fibers And this is the vicious cycle of inflammation in IBM that has been shown by many investigators. So there is, for example, a more recent publication in 2017 and multiple similar publications from earlier on. So this is the T cell side. And very similar, such a fingerprint analysis has been shown for B cells. B cells are also immune cells that are required to produce certain proteins that we need to get rid of bacteria and other stuff in our body that we don't want. And those proteins that are produced by B cells are called antibodies. Antibodies can be used for treatments like drugs, for example, rheumatoid arthritis, and in other diseases, and they're very helpful. There are new biologicals, and there have been many trials for various inflammatory conditions, but such antibodies are also produced in immune conditions and also in IBM. Many of you know that there is an antibody, CN1A antibody. This is an antibody that circulates in about a third of all IBM patients across all countries. So it is not in every patient, and it is not only present in IBM. You see a few patients with other inflammatory conditions of the skeletal muscle, and they also produce this antibody. And much more difficult to really understand why that's the case. Some patients, even without any muscle disease, not only myositis and not even any muscle problems, no muscle symptoms, still also show this antibody. So it is not specific, but we clearly see that within the bucket of inflammatory myopathies, it's clearly the majority of IBM patients that have this antibody. So the summary of this slide is that there is clear evidence that there is a specific immune response in the area of B cells and antibodies active and operative in inclusion body myositis. So now we can switch to the egg, to the degeneration, and see what's going on in the protein world. These are data from 1996 from the lab of Valerie Escanas in California, tech school, and they induced in the muscle cells, they induced an artificial degeneration. They used a vector, a viral vector, with the precursor of amyloid precursor protein, in short APP. They infected the cells, and the cells developed vacuoles, and they degenerated and became smaller. However, there was no inflammation. Another report from 2004 did something similar with also a viral vector, and they introduced amyloid directly into the cell. The cells developed a cell stress response, the cells died, and they had problems in calcium signaling, so that the cell was unable to turn on and off certain cell pathways that are crucial, but still no inflammation. Going a model further up is a mouse model that was generated 2006 by the group around Frank Lafurla from UC Irvine in California, and the first author is Dr. Kitazara. They developed a mouse model with a specific overexpression of amyloid in the skeletal muscle, and they did that by using the enzyme creatine kinase, which all of you know, which is present in the blood when there is a damage in the muscle, and they used this creatine kinase to have a specific overexpression of amyloid in the skeletal muscle, and it worked very well. Actually, it was a little bit more complicated. It was a double transgenic, so not only APP, but also presenilin. And this may ring a bell from one of the first slides that we had. Amyloid, APP, presenilin, these are those genes with exactly the same mutations in APP and in presenilin that are present in Alzheimer's. So these guys you made, if you want to call it like that, they made a muscle Alzheimer's mouse. So they used human transgenes, exactly the same transcript. For example, for APP, called the Swedish mutation. As you would normally have in mouse models for Alzheimer's. But here, these transcripts, they were not present in the brain, they were only present in the muscle. Now what happened? These mice developed a myopathy. The skeletal muscle was impaired, and we could clearly see the damage in the skeletal muscle. But, you can guess, no information. Very recent, from last month, a similar publication with another molecule, TDP-43. This is another protein which is present in many neurodegenerative disorders in the brain and which has been found to be present in the skeletal muscle as well. And this is a group first authored Tavara, and it was published in Experimental Neurology just last month. First, they started off in cell culture and upregulated this protein in the cells, and the cells didn't like it and they died. And then they made a transgenic mouse with an overexpression of TDP-43 in the skeletal muscle, and there was a damage. The mice developed signs of myopathy compared to the normal transgenic. And there was a cell stress response with certain molecules of the endoplasmic reticulum cell stress. This was very nice and very elegantly shown. And then the last panel down here, they compared the same stainings on the level with samples from Inclusion Body Myositis patients, and they found a similar staining pattern. So you could call this mouse and the previous mouse like an IBM similar model, but again, no information. The last part regarding interactions between inflammation and degeneration, we have shown about 10 years ago that the inflammatory pathways indicated here by green, MHC1 and several cytokines are present in the skeletal muscle fibers, and at the same time amyloid is present, which gives the mixture of the color here in yellow, red and green. And we developed a cell culture model in which we exposed the muscle cells to inflammatory cytokines. Most of all, interferon gamma and IL-1 beta in combination. And this has been reproduced now in the meantime by several other groups, and this is considered to be a very robust and good way of mimicking chronic inflammatory cell stress in the cell culture dish. And what happens is, with a pure inflammatory stimulus, and just 3 days of waiting, amyloid kicks in. There is no APP initially. It's just blank. And just by an inflammatory stimulus, what happens is there is an upregulation of the APP. The same APP that has been used in the other studies experimentally, either injected in the cells or injected in the skeletal muscle. So now we have inflammation, and it drives a degenerative response. The cells develop amyloid intracellularly and they die. So we were interested how this would happen. And we looked at one of the molecules that have been shown to interact between inflammation and degeneration in Alzheimer's and in other diseases, and one of the key molecules that can communicate between inflammation and degeneration is nitric oxide. And you can detect nitric oxide by a very simple staining, and the end result is called nitrotyrosine. And I don't want to bore you with too many details. It was present in the skeletal muscle, in those areas where we found the protein accumulation. And when we then looked in the cell culture model, we could identify the same nitric oxide stress in the cells only after exposure to inflammatory cytokines. And then if we blocked the enzyme that was responsible for producing nitric oxide, then the nitric oxide stress went away and we could recover the cell death and we could recover the accumulation of proteins. Another model, not for IBM, but for chronic cell stress, has been published already a couple of years ago, in 2000, but it's still being used. And this is a model which underscores the hypothesis that a very severe and a very long-running inflammation can cause degeneration in the skeletal muscle. So this was a group from Johns Hopkins and NIH, Paul Plotz and Dr. Nagaraju, who is also on the advisory board of the TMA. He is the first author. What they did is they designed a transgenic mouse with an overexpression of MHC1, which is a key molecule of muscle cells and other cells to distinguish between self and non-self. And they pumped up the system, and there was inflammation in response to this. And initially they wanted to create a model for polymyositis, but they failed because they thought they could turn it on and off. It was called a tetracycline model, where the mice are fed with or without tetracycline, which is an antibiotics to kill pathogens. Now, the model worked. They could turn on the MHC1 expression and could turn it off. So they did turn it on. And then they turned off the gene, but the expression of the protein could not be stopped. So a vicious cycle had kicked in after a couple of months in these mice, meaning that if, even with a gene that induces inflammation, and even if you can control this gene, and you can stop the gene to be active, a chronic, smoldering inflammation which causes a cell stress can continue to perpetuate itself. And I think this was extremely elegant, and this is, although this has not been followed for long term for protein degeneration, all of the cell stress molecules which play a role, like ER stress and NO, these are also present in the skeletal muscle. Now going back to the specifics of inclusion body myositis, and in terms of cell stress, there have been X fibers that have been presented by King Engel and published in Neurology 2000, and we were able to reproduce this 9 years later, and we could identify King Engel, and he then elaborated a little bit further on the details of these cells. These X fibers are present in the muscle of IBM, the fibers appear completely normal. They have a normal size, the nuclei are where they are supposed to be, there are no vacuoles, there is no protein accumulation, they look healthy. But they have an indicator of a cell stress. And this indicator is alpha-B crystallin. Alpha-B crystallin is just one of the big family of the heat shock protein preventers, the heat shock protein. There are other heat shock proteins, HSP, 30, 70, whatever, and this is just one of them. So this told King Engel that something is wrong with these fibers. And what we could show a couple of years later is that these fibers were the ones that, even if we did not see any morphological abnormality, no vacuoles, no inclusions, these fibers already contained a soluble form of amyloid inside them. So we would predict, we cannot prove, because we cannot do a repetitive biopsy of the same fiber again and again. This would be unethical, and if you take out a biopsy, that part of the muscle is gone. But we would propose that this is the first step. And then we will have ultimately the protein aggregation. And we could, using our cell culture model again, we could see that, at least in the cell culture, if we would use our model with interferon gamma and IL-1 beta, that these cells develop a similar cell stress response with upregulation of alpha-B crystallin, and then a secondary accumulation of amyloid. So the model of IBM, as we think it holds for the moment, is that we have a collection of underlying predisposing factors, like impaired regenerative capacity. I don't have the time to show more data, luckily for you. And we have an impaired protein machinery. We have an impaired cell stress counterbalance regulation. And in this context of mechanisms and predisposing conditions, an inflammatory stimulus can lead to a degenerative response. And this is connected by a cell stress network of heat shock proteins, alpha-B crystallin, nitric oxide, endoplasmic reticulum stress, and ultimately this leads to a muscle fiber damage. So why is this important? Because we think that this helps us in defining the next steps of hopefully finding drugs that can stop or at least reduce the progression of the disease. So in terms of blocking the inflammation, attractive targets would be, for example, natalizumab, rapamycin, or to block cytokines, and I will come back to that in a minute. In the field of cell stress, what we can do, and this is ongoing, and I'm sure that all of you are aware of that, that arimoclomol is such a drug that can restore at least part of this heat shock protein response. And on the other side, we may in the future be able to improve the clearance of amyloid. For example, rapamycin, lithium, pioglitazone may be active. And possibly maybe for the future, for the very far future, I think in myositis we have to say, we might be able to do the gene correction treatment. All of you are aware of the bimagrumab trial, and I will just mention it later on with one sentence. But there has been the follistatin trial, and also this will be mentioned. But there may be other genes which we may be able to correct in the future, because in the world of hereditary diseases, the rare hereditary, purely hereditary, non-inflammatory diseases, like very severe myopathies, very severe neuropathies, very severe ataxias, we have made a lot of progress in the last years, and new drugs have been licensed, for example, for SMA, spinal muscular atrophy. I don't know if you're aware of that. A new drug has been licensed, and this really is a revolution, I think, in this field. And this is also a new muscular condition, spinal muscular atrophy. So I think it is possible for the far future, but for the moment, probably gene therapy, I mean. So, but I think for the moment, we have to concentrate on the cell stress and inflammation and degeneration, and then maybe dream of the gene correction for the future. Okay, so this is the list of the clinical trials that have been done in IBM, and all of you are aware of the results of those studies, except for some positive and proven positive results of IVIG on the swallowing function. Apart from that, all of these trials have been more or less either underpowered or negative. So recent clinical trials, as I already said, and I will show one more slide later on the mechanism of arimoclomol, is arimoclomol, a phase 2 study, was completed with 24 patients, and now a big trial, phase 2, phase 3, double-blind, is currently ongoing, and 150 patients will be included if everything goes well. But we will need to wait for about 2 more years until we know what's going on. At least probably. Rapamycin, one study has just finished, and I will show you the data in a minute. Natalizumab, that's a blocker that prevents T cells from going into the brain, and this drug is licensed for multiple sclerosis. There has been a phase 1 study, and I haven't seen the data yet. It's a very, very small, just proof of concept study. Then pioglitazone is currently going on. It's a phase 1 study. It's unblinded. It's currently active, I believe, at Johns Hopkins. This is a drug that is used in the diabetes field, and we know that it can help growth of muscles, and we know that, and again, lucky for you, that the PPAR gamma field is also active in the context of amyloid and cell stress. So there are 2 reasons to believe that this may be an interesting target. But of course, these phase 1 studies, they will just tell us that it may be safe in the end. It won't tell us anything about efficacy. And then all of you know, I'm pretty sure, that the bimagrumab trial has failed, unfortunately. This was geared towards the myostatin pathway. There was a big international trial, and maybe some of you in the audience participated in that study, and unfortunately it was negative. There was a small phase 1 trial with follistatin. This is probably brother and sister. Bimagrumab was the antibody, and follistatin is the adenoviral compound, but the end result would have been the same, to block the myostatin pathway. And just one sentence, myostatin is the molecule that tells the muscle to stop growing. And if you block that pathway, the muscle will start to grow and to grow. Well, it didn't work. So now here we are in the world of arimoclomol. Arimoclomol, as we just said, is an ongoing big clinical trial in the US, and I believe one center in Europe, in London, and I'm not sure, I think one more center in Canada, but I'm not 100% sure. Maybe some of you know more about that. And it goes back to ALS. This drug was first shown in 2004 to be operational in a model for ALS, and it was active by helping the endogenous heat shock proteins to stabilize them and to protect the endogenous proteins from degradation. There have been clinical trials, and this is really interesting, I think, now, because there have been trials in the ALS field, clinical trials, and they have been stopped. Nothing really seriously happened, but people, the FDA was afraid of some potential problems with the drug, that there would be side effects. There were no side effects. So then there was silence with this drug over a decade. And now with the new studies in IBM, I saw on clinicaltrials.gov that there is an ALS study now going on with arimoclomol as well. So probably the IBM study now feeds back into the ALS field and convinces the authorities that this seems to be at least a safe drug which probably doesn't do much harm. So there has been a study with many people from the US participating, published in Science Translational Medicine 2016 with arimoclomol in a cell culture model. And it was able, in the cell culture model, to block protein accumulation, both after cytokine exposure and after overexpression of degenerative proteins. And it was able to use that drug, arimoclomol, in a VCP model, valucin containing protein. This is another model to mimic degenerative pathways of inclusion body myositis, but it's a very specific part of IBM. This is not a true IBM. There is no inflammation in the mouse, and also the human situation is completely different, so it only mimics some degenerative factors, but still the drug was positive. And then there was a double-blind clinical study connected in the same publication, so there were cells, mice and human in the same study, and this was double-blind with two groups of 12 people, and this was positive, and these data were sufficient to convince the payers, the funding agencies, and the FDA that a big trial can now go on. Now these data are very new. They were published, they have not been published in a paper. This study with rapamycin in inclusion body myositis has been performed in the group of Olivier Benveniste in Paris. And this was also a double-blind, placebo-controlled trial. And it has been presented at the American College of Rheumatology last year. And what happened is that the 6-minute walk test was improved in patients with IBM compared to placebo. In the placebo group, there was a decline. This is the green line. And the IBM patients remained stable. So this looks promising. Then the functional score, a HAQ score, this is like a questionnaire, a patient-reported outcome measure, was also improved in the rapamycin group compared to the placebo. And the MRI muscle was also improved. There was a replacement score, how much muscle was damaged, and this was also improved. So we think that these data are very promising, and I think we need a bigger trial, which is difficult because the company that produces rapamycin is reluctant to fund a bigger trial. So I think this is very important to convince the public that we really need to mount a large phase 3 trial. Okay, now I would like to shift gears back from all these complicated interactions between inflammation and degeneration, and now let's get more clinical for the last minutes. Swallowing is extremely important, and many patients with IBM suffer from dysphagia. Now, dysphagia comes in, or swallowing in general, comes in various flavors. This is a snake that eats a whole kangaroo, and I don't know if it survived. This doesn't look very healthy, what this gentleman does. And this is how it looks like in IBM. This is a video fluoroscopy with a contrast agent. And normally, in a normal individual, this is just one gulp, and the whole contrast agent is swallowed down. Now, not in all patients with IBM, but in the majority, at least 60%, over the time, such similar dysphagia can occur, and sometimes this can even be the presenting initial sole symptom. So there are different treatments that have been used to treat dysphagia in IBM. One is the balloon dilation. We do not favor that, but it has been published because we would think there is no stricture. We don't think, we know there is no stricture. And we think that such a dilation could cause potentially more damage. But still, some patients say that it's helpful, at least for a few sessions. Then there is a myotomy. This is a surgery. This is a one-time and irreversible surgery of the upper esophagus sphincter. There will be an incision, and the swallowing will improve. But you may have other side effects because you may have a reflux, and then you may have another cause for aspiration, which is, of course, very dangerous. So what we would favor is repetitive injections of botulinum toxin into the cricopharyngeus. So this has been published in 2004, and just very recently, 2017, more case series have been published with this. We have not been involved in this at all. There is another patient in another series in 2016, and here are some images from these publications that, of course, you need you need a tube in your mouth, of course, and a syringe, an anesthesia. So this is quite a procedure, and you may need it repetitive after 3 to 6 months, but it can clearly increase the swallowing function. And now I would need your hand, but you're writing, so I'm fine, I can do it myself. So we think that it would be good to have a technique of, and maybe you can click on the next movie afterwards. So this is a real-time MRI of swallowing. So, and maybe you can click on it again because I was blocking the image. Just tap on the, great. So this is pineapple juice. This is a patient with IBM without dysphagia lying flat in an MRI scanner. And this is pineapple juice injected. This is our lead author on this study, Dr. Carstens. And he has a syringe in his hand. And the contrast agent is pure natural pineapple juice because it contains natural manganese. And this is sufficient to work as a contrast agent. And if you would be so kind, please, to click on this one, you would have to, yeah, great, move the hand. And now here you can see this is the end of the catheter here, and the pineapple juice is injected into the mouth. This is the tongue, and the patient is asked to swallow. And now here you can see the whitish stuff, and the patient swallows and swallows, and very similar to what we saw in the video fluoroscopy, the patient has to swallow again and again until the pineapple juice is cleared. Now, we think that it's interesting to use the MRI because you can use it repetitively. You may be able to use it in clinical trials because you don't need x-rays, and you can see all of the soft tissues. So this is the video fluoroscopy and the radiography. You don't see the tongue, you don't see muscles, you don't see anything else. So we did a study, and this was published 2016, where we compared the current gold standard video fluoroscopy with the real-time MRI, and we could clearly show that the MRI was sufficient to pick up the swallowing impairment in IBM, and that it correlated very well with the swallowing scales in IBM. So we feel that this is an interesting tool, and we're currently working on subsequent studies to provide more data for it. And here we have, and you do not need to click anything, it should start automatically. So this is the same patient before and after botulinum and the movies are started at the same time. So here it's almost cleared now, and you can see that there is still some pineapple juice on the left-hand side. So clearly the video goes on much longer until everything is cleared. Okay. Just briefly, this is a patient registry that we have in Germany, and I think something similar would be good to have internationally. A registry where all of the IBM patients can click on and register themselves. So far this is only in German, but I think we should try to find a way to make it open internationally. And I would just like to point out that we have a myositis group in Germany, so whoever is maybe interested for whatever reason, maybe you travel abroad and you want to make contacts. The head is Schmidt, and there is a website. If you Google for myositis, you will find the myositis nets. So these are researchers, rheumatologists, dermatologists, and neurologists. And this is easy to find, myositis nets.de. So this is here in Göttingen where I'm based. And the patients, they have one part of the page. It's all in German, but whoever is interested. So this is my group in Göttingen. And we have an English-based website if you're interested. There's not much for patients, I'm afraid, but still, if you are just interested in current research and quiz in the group, you're free and you can visit the website. So thank you very much for your attention. So we have a few minutes for questions. If anybody has one.
I have a question. A couple of the medications that you just mentioned, rapamycin and pioglitazone, are FDA approved in the United States for other conditions. Does that give those an advantage? Would you recommend that patients who aren't in a study seek a neurologist or someone who would prescribe those as a study of one off-label sort?
Excellent question, and thank you for that. Absolutely, you're right. These drugs are licensed for other indications, and you have to negotiate with your local physician, with your neurologist, rheumatologist, whoever's taking the lead for you individually, and negotiate if they think it would be appropriate in terms of potential side effects and possible beneficial effect. So for the pioglitazone, I think it's much too early. There's just a phase 1 study going on. So at the moment, I think we should really wait for the results of this to see if it's safe. So I think for the moment, I would not advocate that. In terms of rapamycin, we have several years of experience. For example, in transplantation surgery, it's very common, and it's not just a little vitamin droplet. It has clearly side effects, and you have to be aware of that. And the physician who treats you with this drug should have experience with such drugs. So it's not just a GP who can just prescribe it, but I have spoken to 2 of my patients who are not responsive to other drugs, and they are currently thinking, and we're negotiating with the payers if we can give it to them. Yes?
Yeah, that's another thing. I'm a pharmacist, so it has a really horrible side effect profile. There's no question about it. Although if it's your last choice, or if you've had an organ transplant, and that's what's keeping it from rejection, you withstand the side effects. It's also without insurance, and there's highly unlikely, in my estimation, that an insurance company would pay for it as an off-label use, but it's very expensive. The glitazone is relatively inexpensive.
The matter of expensive is a difficult topic, and I think the new drugs, for example, Spinraza for SMA, this and other new biologicals like antibodies, they cost up to 100,000 per injection. One injection, one treatment, one day. And as a pharmacist, you know about this. So we talk about rapamycin, a couple of $100 each month. This is, I think,
a little higher in the United States, I think.
But yeah, depending on like the negotiations, whatever, but still not 100,000 for one injection. So I think we need to level this, and many times we're faced exactly with that same thing, that the payers are reluctant and they don't want to pay it, but they're paying other things for other indications, for other diseases. So I think we should try, if I was a patient and I see the data, if I would like to try something new, I think I should. I would consider it, possibly.
Okay. Any other questions?
I have a question. On that side of rapamycin, at what point is it theoretically good to try? I have, a much further progression. I'm in a wheelchair all day long, from the time I get up in the morning, and just $200 a month would hurt, but would help delay it and be well worth it. But at what point do you think it won't work?
Again, this is very important, because whatever treatment we give, if the damage of the skeletal muscle has advanced to a certain stage, probably whatever we do won't help. So probably in the far end stage, there is not much use, and you would have more side effects than beneficial effects. So I don't have a precise answer to your question. It's very, very individual. So I would think that if you have a very rapid progression and you have certain functions, for example, if you can still walk, and I see your situation, but just in general, if you're, for example, able to walk, and you feel that if some more damage will add up to the skeletal muscle of your thigh, then you may have the danger of lose the ability to walk, then probably it would be an idea to think of something more aggressive. That's what probably I would think.
That's a good answer. This gentleman has it. He would be a good, I used to be a pharmacist. If this gentleman has it, he would be a good subject, and it would be worth trying. In my case, it's just not worth there's no return on investment. There's more danger than it is.
I wouldn't say that. I think this is a very individual situation. But on the other side, if all of us we work together and we can mount a large phase 3 trial, then maybe it would be good not to take the drug right now, but rather to wait for that trial, because otherwise we would lose you as a potential subject for a much needed clinical trial.
Thank you.
You have a question? There was one in here. Oh.
Okay, we got a couple. I'll try to get here quick.
For dysphagia, you mentioned surgery. Not recommended because it's one way. There's no turning back from it, but and I can understand that. But are there any side effects with multiple injections of the, I'm going to botch the pronunciation, botulinum.
So,
This is Botox.
So what I did say is that I would, as a personal viewpoint, I would not recommend the balloon dilation, which also is a repetitive maneuver. I think the myotomy is excellent, and it works very well. It's extremely efficient, and it cures the functional stenosis. So the problem that we have is a functional stenosis caused by a functional lack of opening of the upper esophagus sphincter. And if we cut this muscle, this problem is solved. So yes, with botulinum we have repetitive injections, but what happens is if you cut this and you suffer from reflux, then you may develop aspiration and aspiration pneumonia. So maybe as a practical point, maybe there has been no study so far. And again, this would, I think, be an interesting area for a clinical trial. Probably if I was a patient with a severe dysphagia, I think I would try out botulinum toxin, see if it works. And then at that point, if you're fed up with the repetitive injections, but still, if it works for you, and if you're then fed up with these injections, then personally I would consider a myotomy. But you would need to find the appropriate physicians for both of these maneuvers. So in the UK and in the Netherlands, this is a straightforward procedure. Particularly in the Netherlands, they have extremely good experience with IBM patients and other neuromuscular patients in such conditions, and it works extremely well for them. Do you need a microphone or the fine?
We got one back.
Oh, sorry.
One back here, and then we'll.
Sorry.
Does anybody have any updated information on the study from the University of Kansas that's about to take place that you mentioned, phase 2, phase 3?
Sorry, can you say it? Oh, back there. Sorry, can you say it again?
Oh, she asked if there was any new information on the arimoclomol study based out of Kansas University.
You mean information in what terms? Of when it's going on, like the local situation, if you can be included in the study? No, I don't have that information. So
just give you a little bit of an update. Orphazyme, okay, they are exhibiting, and there are representatives of the company there who are in a position to answer your questions related to this. Dr. Dimachi is also going to address the group in general very briefly during the medical advisory board update. So the good news is, what I can tell you is that progress is being made. There's more information out there for those of you who perhaps saw Orphazyme, didn't understand what it is. Those folks are the sponsors of the arimoclomol trial. Okay? So they're out here, they're looking forward to signing your cards and answering your questions.
thank you.
And we had one up here in the front.
Microphone's
You had mentioned that the rapamycin needed further study. And my question is, what can we do to facilitate, expedite that process?
Thank you for that question. So I think all of you, if maybe the TMA as an organization is approached by one of the lead organizers for a potential follow-up trial, what you could do is tell the responsible people, the board of directors at the moment, Bob Goldberg, and then his successor, that this is important, and that if funds are available and if funds are needed, that this would be an interesting area to put funds into. And the second would be in order to convince, maybe if one of you has contacts to the higher up level of the drug sirolimus, you could maybe offer help to Olivier Benveniste and tell him that you can make such a contact in order to convince them to invest money in such an international trial. This is, I think, something that you could do. And on a personal level, if you want to help, of course, you can contact Olivier directly. He will be around, and you can get in touch with him and ask him if there's anything else you can do.
We need to wrap up, I believe. In fact, it's been very, very informative.
Thank you.
Myositis Association, helping patients become peers now for the past 25 years. So if you have been diagnosed, here's an organization to unite us. 8,000 members they can boast. For that real strange word that no one's heard, it's myositis. There's an annual patient conference which is just second to none, where you'll learn a lot and network, and you'll also have some fun. And their website is updated with a lot of current news, with lots of info and resources, and much more that you can use, like info TMA compiles, and like lists of clinical trials, and lists of research too. You can review, cause it's all there for you. So hooray for the group TMA. It's the Myositis Association, helping patients become peers now for the past 25 years. So if you have been diagnosed, here's an organization to unite us. A quarter century they can boast. They've been the group that's got the scoop on myositis.